Welcome to COVID-19 update number 27. I am Dr. Thomas McGinn, Deputy Physician-in-Chief and Chairman of the Department of Medicine, and thank you for joining us. If you go to the next slide, you can see that there was an interesting story in the New York Times this weekend about a Northwell program called the CROWN program for patients with COVID at home, and also alluded to another program that we've initiated, the CARES program. If you go to the next slide, the CARES program is a great program that we've just stood up, and it's the COVID Ambulatory Resource Support Program. And the idea is that we've noticed that COVID touches almost every body part and engages almost every specialty within medicine. And we wanted to find a group of physicians that were excited about caring for patients with COVID, particularly those suffering from maybe some unusual and chronic problems. So the CARES program, as I've said, has almost every specialty in medicine. And if you look on here, we have behavioral sciences, neurosciences, geriatrics, pulmonary, radiology. And these are physicians that have said they want to learn more about caring for COVID in their subspecialty. So if you're out there with a patient that's just newly diagnosed with COVID in the acute moment of COVID and you'd like to get some expertise in that space, or if you have a patient that had COVID a couple of months ago and they're having some lingering issues with fatigue or abdominal complaints or loss of smell, you can call into the CARES program, and the number is here on this slide. So one of the spaces that I've been interested in about COVID is what are we doing in physical medicine and rehab? So if you go to the next slide, today we have our speakers today. We have Dr. Adam Stein, who is the chairman of the Department of Physical Medicine and Rehab, will be talking with us. And we have Danny Vankman, who is the vice president of Northwell Health Outpatient Therapy Network. And I asked the two of them to talk to us about some of their cases. And then after that, we have Dr. Narishman and Dr. Levine, who are going to join a panel conversation, and we're going to go over some questions together. So first up, we have Dr. Stein.
Thank you, Tom. I'll share with you two cases that were admitted to the acute inpatient rehabilitation unit at Glen Cove Hospital. The first case is that of a 48-year-old woman who was initially admitted on April 9th to North Shore University Hospital with acute respiratory failure and an encephalopathy due to COVID-19. She was treated with a variety of medications listed on the slide, and after 13 days, she was able to be successfully extubated. 13 days after that, she arrived on the inpatient unit at Glen Cove Hospital. At the time of admission, she had a variety of impairments in strength and balance. She had significant weakness of her legs. They were graded 3/5, just able to move against gravity. Her arms were a little bit better at 4/5, and she had a markedly unsteady gait. Assessment of her cognitive and emotional status using the Montreal Cognitive Assessment, the PHQ-9, and the GAD-7, a measure of anxiety, revealed moderate levels of cognitive impairment, anxiety, and depression. Her respiratory status was that she required supplemental oxygen, 2 liters on admission. And her overall functional level was that she required 50% assistance with both ambulation and activities of daily living. So she could do half of each of those tasks, but required a caregiver to provide completion for each of those tasks. She had a relatively short stay at Glen Cove of 9 days, and at the end of her stay, she had made significant improvements in strength. Her arms were normally strong, and her legs were near normal. In the cognitive and emotional domain, we were able to discontinue quetiapine, and there were notable improvements in a variety of cognitive domains, in particular executive function. Her respiratory status was that she was free of oxygen. She did not need to go home on any supplement. And overall functional level was that she was now walking and performing her activities of daily living just with supervision, but with no physical assistance. And she was successfully discharged home. Next slide, please. The next case is someone who had a much more significant illness. This is a 55-year-old woman who on April 27th was admitted to Long Island Jewish Medical Center with acute respiratory failure, in cardiac arrest, and having sustained multiple cerebral emboli, all due to COVID-19. In addition, she developed a necrotic hand wound due to a radial artery thrombosis. She required a tracheostomy and peg feeding. Over a month after her stay at Long Island Jewish, she was transferred to Glen Cove's acute ventilatory recovery unit, where she was weaned from ventilation and transitioned to trach collar. And finally, on June 8th, about 6 weeks after her admission to the health system, she was admitted to the acute inpatient rehab unit at Glen Cove. Her impairments at the time of admission were more severe than in case one. Her arms and legs were both extremely weak. Her arms proximally were 2/5 in power, distally better at 4/5, and her legs were 1/5 throughout, really only able to twitch the various muscles. She had very poor sitting balance, and she was unable to stand. She had a variety of wounds. In addition to the left wrist wound, she had an unstageable sacral pressure ulcer and bilateral healed deep tissue injuries. Her respiratory status, she arrived with a trach and required 35% supplemental oxygen, and she could not swallow. She was not taking anything by mouth at all. Functionally, she required more than 75% of assistance with her walking and with activities of daily living, and in our parlance, she was dependent for those activities. She had a very long stay on rehab, 40 days, but made significant improvements. At the time of discharge, her legs and arms had become very functional. Both were graded 4/5. The unstageable sacral ulcer, which to be a stage 4 ulcer, had improved to stage 3. One of her heels had really healed. One remained an improved deep tissue injury, and she did have the left wrist eschar. Respiratory-wise, she on the rehab unit, her trach was removed on June 18th, and she was eventually weaned from all supplemental oxygen. And she, from a swallowing point of view, she was advanced ultimately to a regular diet and tolerated thin liquids. Functionally, she left us with the ability to walk with a walker, just requiring supervision, and also to perform activities of daily living with just supervision, and she was discharged home. Next slide, please. So during COVID-19, the rehabilitation unit at Glen Cove underwent an expansion to meet the needs of the COVID patients. We actually added 10 beds and created an entirely new unit. During a good bit of the pandemic's surge in New York, we had our largest unit, 40 beds, entirely devoted to the care of patients with COVID-19. To date, we have discharged 155 patients from the rehab unit, and 80% of those patients have been discharged to their home. To put this in perspective, for all admissions to inpatient rehabilitation seen nationally, the discharge to home rate is about 73%. So we did very well with this group of patients. In addition to just being generally debilitated and weak in a general sense, we saw a variety of additional conditions. Stroke was very common. We continue to see lots of patients with polyneuropathies. We've seen a variety of entrapment neuropathies leading to foot drops and wrist drops, and brachial plexopathies, mostly from being in a prone position. We have seen a really unprecedented amount of pressure ulcers, both in typical locations such as the sacrum and the heels, but also in atypical locations such as the sternum and the face, also likely due to proning. We have seen and continue to see a variety and a variable degree of cognitive dysfunction and profound swallowing dysfunction. As always in rehab, we work in a multidisciplinary team led by the physiatrist. And at Glen Cove, we have a co-management model with our hospitalist colleagues, which has been very helpful. The vast majority of the therapeutic treatments are provided by our physical therapists, occupational therapists, and speech therapists who handle both speech and swallowing. And we have a full-time neuropsychologist to assist with both cognitive and emotional challenges. I mentioned wound care has been an especially big challenge, and we have on-site expertise, but I have to give tremendous credit to Alicia Orapalo from the Wound Care Center, who has provided telehealth visits for complex wounds. Glen Cove has had a an outpatient-based pulmonary rehab program called Inspirations, and we were able to incorporate that program for our inpatients during this time. And of course, we couldn't do any of the work we do without our social workers and case managers handling complex discharges. Next slide, please. So realizing that we were looking at patients with profound physical, cognitive, and functional problems, we created our rehabilitation part of the CARES program. And as you can see here, our mission is to deal with those physical, cognitive, and functional difficulties that are resulting from COVID. Our physicians help with the recovery and treatment of those conditions, and also focus on preventing further medical complications. As in the inpatient realm, we team with physical, occupational, speech therapists, and neuropsychologists. So all the services that are available on an inpatient basis will also be available as part of the CARES program. We offer in-person and telehealth consultations and a variety of interventions for pulmonary, cognitive, neurological, musculoskeletal impairments, and offer pain management services as well. And we also provide referrals and prescriptions for other services such as orthotic and prosthetics. Next slide, please. This is what you'll see here is a schematic of our outpatient rehabilitation program. You can access it by calling 1-888-REHAB-03 or going through the number that Dr. McGinn showed earlier for the CARES program. In the gray circles around the outside, you see where we think we will get the majority of our referrals from our colleagues in internal medicine and primary care, pulmonologists, cardiologists, and then very importantly from discharged patients, both from our own inpatient acute rehab facilities and also from Northwell's two subacute facilities, Stern and Orzac. We also will expect to receive referrals from Northwell's home-based program for patients who have been receiving care at home, as well as directly from the acute care hospitals when those patients need this type of care. We've identified a physician lead, Dr. Edna Oheb-Shalom. Dr. Oheb-Shalom is a consultant physiatrist, and during the surge of the pandemic, Dr. Oheb-Shalom has provided consultative services at both Long Island Jewish and at North Shore University Hospital, where she has seen the gamut of the results of what this virus can do. Dr. Oheb-Shalom will work with our specialty physicians should she need their help, and refer to our outpatient therapy programs that you'll hear about from Dan in a little bit. And likewise, the therapy providers may also be a source of referral to Dr. Oheb-Shalom and our other physicians. Next slide, please. I want to leave you with some initiatives that we're doing in the research realm. Two studies in particular. The first one is a rather large initiative looking at physical medicine and rehabilitation characteristics, symptoms, and clinical needs of COVID-19 patients across the continuum of care. This is a multi-institutional study being led by my colleague, Dr. Susan Waltzer, who is the chair of physical medicine and rehabilitation at Glen Cove Hospital. And she leads a consortium of the 7 large academic medical systems in the New York, New Jersey area, which are listed below. This is an active, approved research project, and we're about to send out our first manuscript, which will present data on the first 50 patients admitted to inpatient rehabilitation from each of those 7 institutions. Next slide, please. The second study that we are participating in, also a multi-institutional study, concerns a specific group of patients, those with traumatic spinal cord injury. Persons with traumatic spinal cord injury are known to have significant immune deficits as part of their injury. And in fact, the #1 cause of death in this population is infectious. So we were very concerned about how this population would fare if and when they contracted COVID. So with the leadership of Dr. Ona Bloom at Feinstein, and colleagues at Mount Sinai, the James Peters VA in the Bronx, and Rutgers, New Jersey Medical School and the Kessler Institute, we are undertaking to examine the effects of COVID-19 on this very much at-risk population. Anecdotally, we've actually been surprised that perhaps the effect is not as severe that we have seen, but we need to look at the data to do this. And this project has already received support from two organizations, the Christopher and Dana Reeve Paralysis Foundation and the Craig H. Nielsen Foundation. That's it for my slides, Tom. Thank you for the opportunity to present.
Thanks so much, Adam. You know, when I hear you talk about those patients and the multidisciplinary effort that goes into it, it's really, I forget how complicated it is, and the effort, the Herculean effort that goes on with these patients. So really, you know, hats off to your team, and I know we're going to hear about your handoff partner for the outpatient side. But really, every time I hear it, I'm like, wow, that's a lot. It's amazingly complicated. So congratulations on that work. So Danny, you're up next. Why don't you take us some outpatient rehab case?
Sure. So first, well, next slide, I guess. So first, thank you for giving me the opportunity to present in this forum. Before we start with the case, what I thought it was important is to kind of review the sequelae that happens with any illness or injury that causes prolonged bed rest or inactivity. And so, you know, again, we know you get muscle wasting and disuse atrophy, you can get joint contractures, you're at increased risk for DVTs, tachycardia, orthostatic hypotension, and of course, decreased endurance or aerobic capacity. And the one good thing is that most of these can be reversed to, at least to some extent, through exercise. And so, you know, that's very important. But I guess also just some background is when we saw, you know, on the outpatient side, when we saw what was happening with COVID-19 leading to these long hospital stays, with many of these patients being admitted to the ICUs, we kind of anticipated the need for, you know, rehab programs that would specifically address the deficits, you know, mentioned here. And so that kind of led to the genesis of the STARS Inspire pulmonary rehabilitation program. And I want to give credit to one of our senior therapists, Mike Cami, who really took the initiative to put this together and work with all the therapists throughout our locations to develop the program. Next slide. So this case, it involved a 59-year-old female who developed significant symptoms consistent with COVID-19 on 3/13 while she was visiting her family in Kentucky. She was then hospitalized in Kentucky on 3/22 due to difficulty breathing, and a subsequent COVID test, you know, was positive. The next day, the patient, I guess, you know, had such difficulty breathing that she was placed on a vent the very next day. That vent was removed on 4/20, which was 29 days after her hospitalization. And then she was DC'd from the hospital on 5/13, which was 52 days after her initial hospitalization. And then she subsequently returned to New York on 5/14. Next slide. So she was referred to the STARS Inspire program with a diagnosis of weakness, shortness of breath, and again, muscle weakness. Her evaluation was on 5/18/20, with her chief complaints being limited standing tolerance, the inability to perform steps reciprocally or normally. She lived in a split level home, so that was important. She was having difficulty dressing, and she just reported a general decrease in endurance with household chores. We had her fill out what's called a lower extremity functional scale. So this is it's a self-report tool that measures 20 functional activities, and it's scored out of 80, and she scored 15 out of 80, which is pretty low. And that kind of helped to summarize or correlate the complaints she was making verbally. When she first came into the program, her baseline vitals, her blood pressure, again, was on the higher side. Her heart rate was on the higher side. Her resting respiratory, again, was outside of normal. Her resting SpO2 was 96 with room air, and she had a modified BORG-1, which is slightly difficult breathing. We also performed some objective testing, and so of significant, the 6-minute walk test, which measures how far you can walk within 6 minutes. Her lowest SpO2 was 93, and again, you want to generally have a score of 95 or above. Her heart rate elevated to 126 beats per minute, and she was only able to walk 561 feet. So for her age and gender, 1,500 feet is normal. And at the end of that, her perceived breathing, the Borg, was a 4, which again, she was saying she was somewhat severe in breathing. Her upper extremity muscle test, again, was grossly 3 to 3+. So just as a reminder, that's barely able to lift your limbs against gravity. Dorsiflexion was 2+, so again, extremely weak. And her quads and hams, again, were in the 3+ range. So again, those muscles are required to basically do any kind of functional activity related to getting out of a chair, transfers, stairs, things like that. So could be an unsafe situation, either walking around the community or in her home. Next slide. So just in case you wanted to see it, again, this is what the modified Borg scale is. And again, patients will look at that and then report their perceived level of breathing. And this is just the lower extremity functional scale, which again, you can look at, but again, it gives a lot of functional activities and helps to, track improvement over time. Next slide. So she came to therapy, like I said, and you gave her baseline data. She's been in therapy for 17 sessions at a frequency of 2 times a week. Her interventions focus on endurance activities, upper extremity, lower extremity, core strengthening, and breathing exercises. The follow-up scores at visit 17 are below. So again, you could see her BP went to more normal levels. Her resting heart rate was, again, more within a normal range. Her respiratory rate is still slightly elevated, but better. Her resting SpO2 went up to 99 at room air. And again, at that rest, she perceived no difficulty breathing. The objective testing, again, the left score improved from that 15 baseline to a 42. The MCID for that is 9 points. So again, that's significant improvement. Her 6-minute walk test, again, her lowest SpO2 was 94, which improved. Her heart rate wasn't as high at 102, and her distance improved to almost within normal limits. And again, with a Borg 2, again, slightly difficult to breathe at the end of that. And then her upper extremity strength significantly improved to functional limits, both on her upper and lower extremities. So again, making her much safer and more functional, performing, home tasks and community tasks. Next slide. So I just wanted to give you a sense of the overall. So these are our first 10 patients in the Inspire program. And again, this gives the baseline and then the follow-up testing data. So again, there's been overall significant improvement through this whole group with doing a structured program. We have 24 patients in the program now, and we'll continue to track this data. And, like I said, hopefully it'll be as good as what we're seeing here. Next slide. Just in case, again, this program is a need for your patients. Again, we have 15 locations, with the bulk of them in Nassau, but we have them in Suffolk, Queens, Manhattan, and Westchester, with therapists trained to perform this program. So the next slide, if you can go to that, just kind of gives how you can refer. So again, you can put in a STARS referral through Allscripts. We have a concierge line or an email box or a phone number which you can call to get your patients signed up for the program. So again, thanks for having me and allowing me to do this. And
great, Danny. Thank you so much. And again, amazing work for very sick patients. What a case, how complicated and what a difficult scenario for her, but amazing recovery. All right, let's go to our panel conversation. And if we can flip over to the panel scene, we'll have Mangala and Nancy join us along with Danny and Adam. So welcome. Thanks for joining us. Mangala, let me ask you, you presented in Grand Rounds today an amazing overview of the experience in the ICU. Means maybe a difficult question, but hearing about these cases, like you helped create, you were part of the process of creating these programs along with these guys. What are you thinking? What's running through your head as you hear about all the weakness and debilitation, and what a team effort from the minute it hits the emergency room, gets into the ICU, ends up in rehab? I don't know, what's running through your head? This is a big open question.
So impressed when I hear those cases, because we see those patients up until the time they're discharged from the hospital, and they're a mess and they can't move and they're depressed and they're so weak that they can't swallow. We leave them with trachs, and to see what these guys do with them afterwards, it inspires me, and it gives me hope that what we're doing in the ICUs is worthwhile, because they are going back to normal lives because of what these guys are doing. So
yeah, right.
thank you.
I think that's it's nice to see the other end of the spectrum.
It is.
As they come out, particularly when you hear
Yeah.
about some of the proning ulcers. That's a kind of scary thought, Nancy, what about you? You're primary care world, and are you thinking rehab at all as you see your COVID patients, and where's your head with all of this?
So it's interesting because certainly the more severe patients who have been hospitalized in the units with these long protracted courses is definitely the patient. Lots of times by the time they've come back to me, they've been through this process. So it's like Mongo said, it's great to know that they went into the hospital, have had this long course, and suddenly they're human again. So thank you for all the work you do. The one thing I also see is those patients that maybe weren't sick enough to be hospitalized.
Right,
But
yeah, that's what I'm worried about.
Yeah, got taken out by this. And how do they recover? When do we know when they would benefit from?
Danny and Adam, what do you think of that? I memean, I've cared for some. I know Nancy's done a lot of patients beat up at home for a month, lying in bed, never went to the hospital. Adam, what do you think? Should we be referring these folks for rehab? And I guess, Mongo could maybe pulmonary rehab.
It all comes down to function. So that's what our specialty was founded on, treating people with functional deficits, whether they're from whatever cause, whether it's pulmonary, neurological, musculoskeletal. And if those patients,
So how would you say that? And I like it, actually. It's a nice way to kind of demarcate that line. But so, for example, functional somebody shows up in Dr. Levine's office. What does that mean? I just had COVID. I've been out of it for a month, and hey.
Dr. Levine, I can't get out of bed. My daughter has to help me up to get out of bed. I can't take a shower, and I can't I can put on my shirt, but I can't put on my pants.
Right.
So it's really the ADLs and the IADLs. That's actually a really great way to triage it. Lots of people feel weak, but I guess turning it into a real functional status is
I like that too. I think that's and I know in psychiatry they talk about you can have this disorder, but when it becomes a problem, then it's a DSM category when you can't function. Danny, are you seeing anybody that's not been discharged from a hospital right now? Most of your folks are discharged from a hospital.
That's correct. So of the patients who we have, right, pretty much all of them have been hospitalized, even whether for a longer period or a shorter period of time. But yes.
Yeah. And Mangala, the delirium, to me that's once you're that sick and you're delirious, that functional stuff goes out the window at that point. To me, you can't really, and that seems to be a snowball effect. What's your thoughts on delirium and things in the units?
This was a very specific problem to COVID. We saw a lot of very, very severe delirium with COVID patients because of the amount of time they were on sedatives and the number of sedatives they were on when they were on ventilators. So it took us a long time after they even came off the ventilator to get them to a point where we could get them to Dr. Stein to get rehab because of the fact that they were so delirious. So that interplay of cognition, delirium, and and being able to do the rehab seems something we underappreciate, that if somebody can't follow instructions, they can't go to rehab. Exactly. And what do you think about that? How does that play out in your strategy in rehab when somebody shows up in acute rehab, varying degrees of delirium, and how does the team approach that?
So I would say that it's no accident that every rehab team has a neuropsychologist. So one of the main groups of patients that we've treated for years are people with traumatic brain injury.
Sure, right. Yeah.
They have a variety of behavioral problems.
Right.
So we actually have quite a bit of experience treating those folks both medically and situationally. So yes, they need to be able to participate, but I think they may not require the degree of clearing that you think.
Have we seen any folks not, Danny, I'll throw this, come back all the way in the cognitions or the delirium? Have we seen some permanent damage? I'm talking outside of the stroke group. That's a separate group. I mean, COVID is notorious for doing that. Do you see any lingering cognitive impairment that you think you can pin on COVID?
I mean, in our setting, I wouldn't say we've noticed that so much. I think, that would be an interesting question if we had someone maybe in the home care setting or when they first go home on doing that, as opposed to later.
I guess we won't know. We're not really measuring it just yet from pre to post and all of that.
Well, one of the first research study that I mentioned to you, we will be measuring it actually, and we expect to be able to tell you the answer to that question over time.
All right, I think we're going to have to wrap up, but it's interesting. I didn't know. I mean, I thought about inviting you, Mangala and Nancy to this conversation, but this spectrum from intensive care, proning and days on the vents to a handoff to acute settings, to the outpatient setting, and then landing in the primary care doctor's office. I wish I could tell you that I had planned it that way, but I did not. And I really, again, I keep saying this, and I see Mangala now after she presented at Grand Rounds and the amazing work her team did. Nancy's, team worked, both in the hospital and caring for COVID patients, and now to hear the two of you and the amazing programs that you've stood up for COVID patients, it really is remarkable. And I thank you both for your amazing efforts and focus. It's such hard, detailed work to get people back like that, and such patience and caring, just kind of comes right through. So thank you for doing that. And
Yes,
all right,
so
it really is amazing. All right, so everybody wants to know a song. I have bad news. I'm not allowed to play the songs anymore. So
we know you can't sing, so please.
I am not going to sing. Thank you, Mangala. I appreciate that. And you're right. My daughters would tell you I can't sing. But the song that came right to my mind, of course, is Amy Winehouse, Rehab. It's a fabulous song, so go listen to it. And remember, if you go to the next slide, please send us some emails and comments about what you thought of this, what other topics you would like to talk about. We're going to be revisiting, some other topics again. We're going to get a follow-up from nephrology on what's happening in nephrology and COVID. The next two episodes, Dr. Levine is going to be your host. I'm very excited to take a break and go on a little vacation. So we'll see everybody next week, and thank you for listening.